Oh, yeah.
This is some quality key lime pie.
Amazing, right? Straight from Florida.
Fantastic.
Couldn't get better.
I've had nothing but bad key lime pie. I realize now my whole life.
Yeah,
I've
welcome.
led a sheltered life. Hey, we got to do the show soon. What's in the news today?
You're never going to believe this. This guy in Germany, piercings, next level. Probably a dentist's dream, though. You have any piercings?
I'm not sure. No.
Oh, gosh.
It closed up.
Thank God.
I had one.
Yeah.
No, I didn't have one, but.
Thank you. And what about the case of the week?
Case of the week is just crazy messed up patient. Looks like it's mounted upside down. It's like, like the lower jaw enters the room like 3 minutes before he does. He's all the worn downs, missing half of them.
Oh, yeah.
Dude's just messed up. Dennis like, what the hell am I supposed to do with this? So he sends it to us, and we're going to tell him what his options are.
We got the solution?
Oh, my God.
I like it. Just go for it.
It's pretty. Oh, they're rolling.
Yeah. Oh.
That and more on today's Chairside Live. Hello and welcome to episode 101 of Chairside Live, or episode CI in Roman numerals. What up,
Fancy.
Rome? Just making sure that they feel that getting the love from us over here.
Oh, yes, I love Rome.
Well, we've got an interesting episode today. It feels
do.
like a new era, the 101st episode. Those first 100 are behind us, and now it's time to move on. We've got a great case of the week. We're continuing our tour of the partial denture department. Seems like a great summertime topic. And today a doctor sends in a case, an interesting case, an overclosed patient with a class 3 bite. It's really just a total mess. And the doctor wants some advice and wants to know what his options are. And we're going to go ahead and present those to the doctor. In fact, let's take a look at that now. I was walking through the partial denture department the other day and saw this doozy of a case. A doctor sent this one in requesting a review and a proposed design of what we could do. You can see the patient's missing teeth number 3 through 10, but has some nice rest preps from the existing partial that they had before, which is broken. In fact, it's got a history of the teeth breaking from the settle several times. And if we look, we can see there's little room for denture teeth from 3 through 5 at least. And you can see the class 3 arrangement that we have there. If we were to put denture teeth in there with this bite, the denture teeth would be very, very thin and most certainly fracture. Patient's coming back to doctor angry again. And so as we look at it and try to figure out what it is, we see the patient has a lower partial denture and the teeth, the acrylic teeth, are basically worn down to the mesh at this point. And so you look at this, and that's where this tooth has been hitting, just eating down into that, whereas before it was probably up on a normal occlusal plane, not quite that tilted, but the bite was definitely open before. So there was a couple of different options that were run by the doctor. The first one was remake the patient's lower denture as well. There's been a lot of wear on the other side, not as much as over here, and there's an anterior segment to it as well. But if the lower denture gets remade, all of a sudden the teeth, for example, can continue along the occlusal plane here, along kind of a modified curve of Spee, and at least we'll have enough room then when the patient bites together and stops here for the rest of those teeth that are on there. And the patient called back and said, the doctor called back and said the patient can't afford this option. So another option would be for the doctor to take a pickup impression with this partial in place, and then to pick it all up, send it out to the laboratory, and we could pour that, and then we could add new teeth onto both of the saddles, and we could do a wax up on the opposing and get an appropriate plane of occlusion on this lower denture, and then fabricate the upper to that and send them both back to the doctor to have them be delivered at the same time with the occlusion adjusted. Or the last thing is the doctor could, and this might be the most affordable just in terms of the lowest lab bill, the doctor could build these teeth and a little bit over here back up again with tooth-colored acrylic perhaps, or composite. Composite doesn't necessarily stick at all to denture teeth, but with enough potholes in here, if he wanted to use composite, he might be able to do it, or use some acrylic to be able to do it as well. So the doctor like the idea of building it up with acrylic, almost a block as much as the teeth, just to be able to open it up. And so the doctor is going to build that up and get an impression of that for us and get a bite. And in the meantime, the framework has been made, and so I'll put this into place. And you can see that number 11 has been clasped with again, we would term this an aesthetic clasp because it's not out on the facial and therefore readily apparent. Any clasp on number 11 usually will be seen. And so there's an undercut on the mesial, and the opposing does not interfere with the lingual. And so there's room to come off the cingulum and wrap this around the lingual and onto the mesial into that undercut. The doctor approved the horseshoe major connector that matched the patient's existing partial denture, and we try to design the major connector as similar as possible to what the patient has already accommodated to, in the past to their tongue. So even if we see something that might be a more clever design or might be a smaller palatal strap, if the patient is used to something and hasn't complained about it, it's often the best idea to go ahead and replicate that and make sure that they don't have to learn something all over again. So if we can see the indentation on their palate where that was, that's even more helpful. Again, we have an eye bar over on this side. This tooth has already lost some of the attachment, and the eye bar is a very kind way to be able to clasp that compared to a circumferential clasp like this one, but that tooth is much stronger than that bicuspid and doesn't have the same attached gingival loss and perio issues that the bicuspid does. So the doctor is going to build up the lower denture with composite, open the bite so that there's room, because otherwise it would be very difficult, as you can see, to place denture teeth in acrylic there. And it's no wonder the patient has continually broken the teeth.
And now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. James Beck, and he writes in and says, "Dear Dr. D, I love Chairside Live and watch it religiously, but I was wondering, why do you talk so much about traditional impressions? The wave of the future is obviously digital impressions. I have had an iTero by Cadent for 2 years and could not live without it. Not only does it scan for crown and bridge, but also for Invisalign cases. Could you talk more about digital impression technology? I think if we all started using it, the prices would go down. However, the price of my iTero payment is money well spent, considering I save chair time at delivery, don't have to buy as much VPS, trays, and other impression supplies, and the patients prefer the scan over impressions, and the technology is just cool and impressive to the patient. Hope to hear back from you, Dr. James Beck."
Well, James, that's a great question. And is, in fact, the future of dentistry digital impressions? I would say yes. I don't think it's going to be in the next 5 years. In the next 10 years, to me, is probably a little bit of a better guess. For example, last month we got roughly 120,000 impressions for crowns and bridges in here at the laboratory. And out of those 120,000 impressions that we got, right around 4,600 were digital impressions. And so it's still a very small part of the incoming impressions to our laboratory, and we're actually getting more digital impressions than any other lab in the country, and it's still, a pretty small portion of what's coming in here. And so for that reason, I have a tendency to focus more on traditional polyvinyl impressions, because that's what the majority of our dentists are still doing, are taking those impressions. Is it the wave of the future? It seems like it. It feels like it, because there's certain things we can do. The one thing that I do tell any dentist who asks about it, about digital impressions, is that there is simply no faster way, or no easier way really, to get better as a dentist than to start taking digital impressions. I just noticed it in my own preparations as well, as soon as I start taking digital impressions and blowing everything up on the screen. So you're not looking at a prep anymore with 4x loops on. You're looking at a virtual model on a screen that's 30x, the size of what you can see with your loops on. And that's when the learning really takes place, because you can look at something blown up on the screen, You can see a little chip out of the margin or a rough spot, or typically where the margin on the lingual goes to meet the distal and it's not quite a very smooth transition. And you see it blown up on the screen. Then you look back at the tooth with your loupes on, and now you can recognize it. You couldn't see it before, but when you've seen it blown up, your eye learns to recognize what that looks like when it's on the tooth. And the biggest difference is right there. Instead of looking at a polyvinyl impression, which is a negative, it's an impression of the tooth, and you're looking at it trying to interpolate in your head what this model is going to look like when it's poured up. And that's the big advantage the lab has, is when we get a polyvinyl impression, we pour it up and look at the stone model, and you can instantly see what's wrong. Like at my lectures, when I show bad impressions, you'll hear the whole audience groan, all the dentists, when they see this just awful impression, and you know it's awful, but you can't say exactly why it's awful. Then as soon as you see in the stone model, it's clear as a bell. And that's the big difference with digital impressions. You're no longer looking at an impression. You're absolutely looking at a virtual model on the screen, and so you get to see the positive as though it had been poured up, and that's why you become such a better dentist when you do that, if you want to become a better dentist. But if you just look at the time involved, for most dentists, the 27 seconds that it takes to squirt the polyvinyl around the tooth, put a double arch tray in the patient's mouth and close, and dentist walks out of the room, versus the 90 seconds or more that it takes to do a digital impression once you get proficient at it, keeps them from wanting to do it. And so yes, I don't know if the more we buy it, the price is going to come down. I think the more that we see intraoral scanners, more systems come into place. Last year at the IDS meeting, there was probably 13 new scanners over in Europe that are slowly going to start making their way over here. And it's that kind of competition, I think, that's going to help drive prices down. People adding features. Sirona, for example, has now added where, OmniCam users now have an ortho module that's going to be released in a couple of months, where they can do kind of like what you're doing and send things out to ClearCorrect for some invisible aligners that they can put on the teeth to do some ortho like you currently do with Align. And I think as we start to see more features built in, the Sirona system now allows you to actually mill surgical guides to place implants. You can mill Emax abutments. The more uses that are added to this, and whoever comes up with the breakthrough technology, and I'll put my money, I don't know, I would guess Sirona, just because they've been leaders in the industry. But whoever comes up with the breakthrough technology where you can put it in the mouth and it's going to scan the entire mouth, including the prep, in maybe 5 to 8 seconds, and it's going to be able to differentiate between blood, saliva, soft tissue, bone, tooth structure, whatever that technology may be, because it's not laser yet. Laser can't see through all of those different tissues, can't see through blood, can't really do subgingival margins very well, and a lot of dentists tell me most of the crowns they do these days are redo dentistry, where they're taking off an old crown with subgingival margins. They're not doing crown lengthening, or even going in and using the laser to remove some tissue. So it's a subgingival margin, and those are areas where it can be a challenge with a digital impression. But you will definitely hear me start to talk more and more about it as that number increases and continues to go up. We see a lot from Pacific Dental, a group of 400 practices across the U.S. who have now done over 30,000 digital impression cases and over 700,000 in-office milled Emax crowns. And so we do see it continuing to grow, but it is a slow growth, and the majority of dentists that we work with are still sending conventional impressions, and that is why I still talk about conventional impressions more than digital impressions, even though I do agree with you. It is the future of dentistry. I just don't know if it's in the next 5 years. It depends when that breakthrough technology actually comes out. So we have a nice little gift for James. I'd like to give him one of my favorite items. It's actually just the closest one to me right now.
Okay.
And that would be the Bruxer Adjustment and Polishing Kit.
Love it.
And I know we're going to have a signed picture for him as well.
Of course. And this is actually hilarious. This is from our 100th episode, last episode, and you're mid-sentence, probably talking about conventional impressions, and this is me just with giving the side eye.
Yeah,
I don't know about that.
I'm not sure what you're glancing at over there, because there's really nothing to your left here on the set.
No.
What you're saying, I think, with your eyes is anything's better than looking at this guy. Right? You'd rather just stare at the curtain.
And before you talk about that, I also have another gift for him.
Oh, really?
Yeah.
What's that?
How about this?
The Chairside Light car cover.
No, it's an apron.
Oh, it's an apron. Do we know he cooks?
No, we don't. But
okay.
Maybe if he doesn't, he should start. And we've got the summer coming up, so it's plenty of barbecues.
Barbecue weather. And we'd be remiss if we didn't mention our viewer mail winner from a couple weeks ago.
Yes.
You threw something out there.
I did.
You got on your hands and knees, even though you're 31 weeks along, and
32
begged.
today.
All right. Close enough.
I did. I totally humbled myself and begged for a key lime pie from Dr. Stephen Devins because he's from Cocoa Beach, Florida.
Right.
And he wrote in, and the previous week we had Dr. Wind who gave us the sourdough
That's
bread.
great. I'm still chewing it.
Yep, from San Francisco.
I got here late to that party, so
okay.
that's why.
And so I just pleaded and begged, and you know what? Ask and you shall receive. Can you believe that Dr. Devins sent us straight from the Keys?
Look at that. Key lime pie.
Key lime pie.
Oh, that's amazing. And
Oh
the
my
best
gosh.
part is, because I'm flying to Montreal for a lecture, we had to do this show at 8 in the morning. And so key lime pie, it's not just for dessert anymore.
No, it's
this
for
is
breakfast.
the breakfast of
and
champions.
There's really nothing better. So I am very excited. Let's
Excellent.
try it.
Well, Stephen, thank you so much. I am going to try it.
Oh, right in there.
Yeah, just randomly. You go ahead and
Okay.
start doing the news if you would.
Oh, okay. You get to eat it first.
That's right.
Awesome. And
That's
even though
right.
I asked for it.
I'm going to
But
scrape all over the top.
Stop. You know that's the most annoying
Don't
thing
you
to
hate
me.
that when you see teeth mark? Oh, you want a bite? Here you go.
Oh, gosh, no. But yes, thank you so much, Dr.
Oh,
Devins.
wonderful.
But what if you could examine someone's oral health without having to open his or her mouth? Well, if you're dealing with 23-year-old Joel Migler from Germany, you can do just that. Migler has stretched his cheeks so much with piercings that you can see his teeth from the side of his face. He has 25 piercings, plenty of tattoos, and a bifurcated tongue. The holes in his cheeks are currently 36 millimeters wide, which is approaching 1.5 inches wide. He says he has cut his cheeks 3 times and continues to stretch them. Migler says he has been experimenting with body modification since he was 13 years old, and that he can still eat and drink like normal people.
This is nuts. This looks photoshopped when I look at this. When I look at this picture,
it does not even look real.
This looks like. This actually gave me an idea. We used to have those teeth where you could bite on it. It would be great just to have a little sticker that you could put on the side of your cheek that made it look like you could see your teeth through your cheeks. That's kind of what it looks like, but.
And it looks like almost, if you look on his nose, he's got another one of those piercings, and I don't know if he's got the same plans for that one.
Right.
I mean, he can.
How you feel about this one? There's his bifurcated tongue.
Yep.
Which is a good look. It just looks fake, but it's now coming through the ring in his cheek.
And my question is, when he takes it out, then what? Like, it's just like.
He puts. I think he might put like a little stud in there to keep it closed, to keep the food from like falling out of the side of his mouth. Here, for example, is there's his bifurcated tongue. But let me go back to this other one where you can see his tongue. If he moves his tongue, or if you look at the very first picture, this is a dentist's dream. The cheeks are always getting in the way. I can get a handpiece right through there.
Right.
This is access to a molar like I've never had before.
So are you suggesting everyone do this?
I'm just saying, no, I'm not suggesting that. I'm
Thank
just
you.
saying that what a dream. Like, it's tough sometimes for assistants lining up a bite wing x-ray
Sure.
because you're trying to shoot it right in between the content. It's perfect. You can see right through there. I'm just saying that this is a parent's nightmare,
Right.
but a dentist's dream, as long as it's not your son. And in this last picture, this is with a lot of the different apparatus in.
Right. I'm not sure. We got something hanging.
There's so many things kind of hanging here that it makes you wonder.
Right.
He must not fly much. I just want to see a video of him drinking water.
Okay.
I just want to see what happens. I think it'd be really.
Just a human
He could probably
fountain.
put a garden hose in there and just turn it on halfway and lay down and kind of be a human fountain.
Right.
Yeah,
which
that would
is
be some living art,
terrifying.
something like Yoko Ono would do.
Okay.
All right, I can't look at this anymore. Anything
I know, I'm
else?
done. Yes. A dentist in Idaho was in the middle of a root canal when an unexpected visitor with an unexpected delivery turned the entire day around. A woman came in the door and wanted to surrender her newly born child. The young mother, who looked like she was in poor health, had just given birth at home and walked to the office. The baby girl weighed about 4 pounds and was just 5 hours old. She wasn't even wearing a diaper and hadn't been fed yet. Under the Idaho Safe Haven Act, new mothers have 30 days to surrender a child to a hospital, a doctor's office, or even with emergency personnel. Fortunately, the little girl is doing well and was taken in by a local couple the same day she was given up.
Okay, it's an interesting
Yep.
law.
Yep.
And I could see giving it to a hospital. a doctor's office, emergency personnel. It's the dentist office that seems a little odd to me.
Yes, I think she must have been, I mean, and this is just pure conjecture, but I'm thinking that was the closest medical-ish
Oh, that's true. Maybe it might have said
office.
Doctor on the sign or doctor on the door.
And so I'm thinking because she walked by foot and had just given birth 5 hours ago, can only imagine, that she was looking for the closest thing possible.
Right. And I want to make it clear, as much as Megan has begged for sourdough bread and key lime pie, we don't need any babies sent here or dropped off. We're going to stick to the food items. And it sounds like they handled it pretty calmly and pretty coolly. I mean, it's kind of...
Yeah, you know what's interesting is that the front of the house manager, the office manager, it was her first day in that position as the full-time manager, and so she was aware of the law, but obviously had never encountered such a situation. So she came in and she just kind of calmly asked her the necessary questions, and then she said, "Do you need anything?" And the lady, I guess the mother, replied that she just needed to go home and sleep. So then they took the baby, and actually the dentist called his mother, who lives nearby and is retired, and she came and helped, and then they brought the baby to the hospital, and then a local couple took the baby in. But being 32 weeks today and feeling her move actually right now as we speak, I feel for that mother, because she must have been in a horrendous situation to want to give her baby up.
Right.
Just to strangers, and I can't even...
Well, there could have been drugs, alcohol, or all kinds of things.
But as the dentist was saying in the story, that he was so proud of the woman because clearly she was unable to take care of the child, and she did the right thing by giving it up to somebody who can actually take care of her versus whatever situation she unfortunately found herself in.
It's just so bizarre that it was the front office person's first day there.
Right.
And I think now that I would do that on a working interview.
Yeah.
I think that would be I wouldn't tell the front office person, but I go, let's have you work for a couple of days and see how it works out, and then have the baby show up during the working interview. Not a real one, but just to see how they handle a crisis like that and see how they get through it. So wow, interesting. What state was that?
Idaho.
Okay.
Nampa, Idaho.
Interesting. I'm going to be up there this summer in Sun Valley for the Idaho State Dental Association. And show of hands, I'll ask them how many have had a baby dropped off at the office. I'd like to see.
Right, okay.
Bet it's less than 50%. I'm just going to say.
I think that so far since the law was enacted, they've had about, I believe it was roughly around 25 babies surrendered.
Now, is it just babies? Because we're kind of having a tough time with my 17-year-old daughter right now. Is there a upper age limit that they set?
I don't think so. They have no.
She's
absolutely.
kind of a baby.
Okay, listen.
You should see her. She's
the mother has 30 days.
Oh, it's
You're
a 30
way
day.
past that.
We are.
So, but California has the same law.
Right. We do?
Yeah.
Oh, I didn't know that.
Yeah.
Well, we've just had nothing but key lime pies dropped off. And
Speaking
I know you're
of,
ready to
already,
dig into that delicious thing.
You got to eat it and I didn't.
I know.
This is so weird. I thought we were going to cut it.
Dr. Devins, if you want me to smash it in your face, hurry and text me. I got my phone right here. I'll feel it vibrate.
No.
You got about 10 seconds left before we...
No.
That is wonderful. Thank you so much for that.
Yes.
And thanks for hanging out and being around for the 101st episode, even though you're getting close to your last episode. We need to figure out what to do, how we're going to replace Megan while she's at home on maternity leave. I know we're going to miss you. It's going to be awful. Who is going to get food sent here? Maybe that'll be my burden from now on. We'll see what happens. Well, that about wraps it up for episode 101 of Chairside Live. On behalf of myself, Megan, the Key Lime Pie, and everybody here at Chairside Live and the laboratory, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. Thank you for that, Dr. D.
You're welcome, my lady.
Okay. And now let's go to a segment we like to call Viewer Mail.
I'm just saying that this is a parent's nightmare, but a dentist's dream, as long as it's not your son.